we're going to transition now to our case presentation, and hope you'll join us, and we'll let you contribute to the discussion too. So I'm going to hand it over to Celine, who I think has a follow-up from her earlier case presentation to share the update. So go for it, Celine.
Yes, so let me just pull up the document.
Hold on, Celine, real quick. We can't hear you very well. Can we just test your sound a minute? Let's see if we can get you a little louder. Can you speak up a little?
Yeah, can you hear me now?
It's pretty muffled. Is your microphone covered?
I'm not sure. Hold on, let me take my laptop off the dock and see if that helps.
Hold on one second, everyone. Let's see if we can get Celine just a little louder for us. You'll see on Becky's screen while Celine's getting set up, you see the some follow-up stuff, and this is what happened since then. Yeah. Okay. So this is what's happened since the original case presentation Celine presented. I think was our first case. Is that right? Our first case. Very first case a couple months ago. So we can, while Celine's getting set up, you can read at your leisure.
Can you hear me now?
Yeah, that's much better. That's much better. Thank you.
No problem. Sorry about that. So yes, as far as, should I just jump in? I can't hear you.
Yes, Celine, sorry, go ahead. Yes.
Okay, cool. So as far as the follow-up for my case presentation, the client that I work with, she came in for an appointment with their primary care provider. Her and her partner did at the end of February, on the 25th of February. And they had a discussion where she talked about in the past, before her and her partner were back together and his health had declined when she took on responsibility for his care. As I mentioned in the first presentation, before that, she had been able to quit smoking without medications. And she said that she wanted to try that out again. She had tried some medications at some point in her quit past, but she remembers at some period she was able to do it without, so she wanted to try that first. But she did think that it would be helpful for her partner to have some medication because he was having a lot more trouble with quitting, and his smoking made it more difficult for her to smoke. So he was prescribed Wellbutrin on that visit. And during that visit, the client also met with one of our behavioral health consultants who provided some counseling on triggers. And then later, earlier this month, she came in because she's been having panic attacks every time she goes to dialysis. She's at a new dialysis center, so it causes her, I guess, whatever the process they use there, she's been having some trouble maybe coordinating that. And so she was prescribed hydroxyzine for the anxiety. And she wanted to start meeting with a behavioral health consultant on a regular basis, just for counseling, for smoking cessation and for anxiety management. And she made an appointment to actually come back and meet with a behavioral health consultant and missed it, but she does say that she's definitely still interested and is going to work on rescheduling that. Let me pull up. And so some of the things I did was to just really validate her decision making and encourage her to, go ahead with her first attempt as far as not using any medications. And I helped her with scheduling and making sure that she had transportation to get here. And I also worked with the provider and the behavioral health consultant before her appointment so that I could give them a heads up about some of her history and what she was working on, and her other goals. So I think that helped the conversation, being able to have that background information, that detailed background information. And she really enjoyed talking to the behavioral health consultant. She hadn't really thought about the process of bringing awareness to different triggers. And so she started looking out for things, and the behavioral health director told her, or consultant told her, to look out for triggers and try to find other coping skills. And so one of the things she started to notice is that every time she would have coffee, that would kind of, lead her to having a cigarette. And so one of the things she tries to do is switch to decaf coffee in her journey to eventually decrease coffee use as much as possible, since she knows that that makes her want to have a cigarette. Another thing that helped her was the provider telling her to say things out loud, like, I'm going to quit, I'm putting this out now. So she'll find herself having half a cigarette with her coffee, and she says out loud, I'm putting this out now. And then that encourages her to kind of ash it. And I think just that process really helps her with bringing awareness to her patterns and her behaviors. They also discussed, well, she's gone from smoking 1 to 2 cigarettes with a cup of coffee to now half a cigarette with the decaf coffee that she's having. And then the medication really helped her partner, because he's gone from 3 packs a day to 1 pack a day. And one of the things that helped with that is she decided to hold on to the cigarettes for him. And so he'll have to come to her when he wants to smoke, which could be helpful for just kind of managing how often he's smoking, that he doesn't have access to them as easily as before. And he was comfortable with that. And since he decreased his smoking, he's talked about, you know, things kind of have a different smell, different taste. And so she uses that to encourage him to continue with it. And he's even noticed like the ashtrays not smelling so great, which is why they tried to start washing them out now. But she was saying just the fact that he is having complaints about the ashtray is something that wasn't happening before. So that's a noticeable change. And so, yeah, kind of washing the ashtrays out has helped. And so for next steps and follow-up, we talked about her needing housing. And she specified now that they want to find housing that has a no smoking policy to kind of help with their goal. And we had some luck finding something, but then had some issues getting back in touch with the property manager. So the housing search continues. But now that she's really into kind of building that awareness, she is working on having a smoking log. And we're going to have a place for her to write down when she's having the cigarette and maybe what are the situational factors to her having that, so she can continue noticing, you know, what kinds of situations lead to her craving cigarettes. And then her and her partner also plan to enroll in the Freedom from Smoking class that will be held at Shawnee around late May. And I told them that the 4th session of that program involves having a quit day. So we're at the day that you officially say, I'm quitting. So we're hoping that the strategies they're starting now will help them be prepared for that quit day when we have those Freedom from Smoking classes on that 4th session. And she was really excited and motivated by all the feedback and the recommendations she got. You know, she would really give it a 5 rating, and I think I would too, because I'm learning a lot more, not as noticeable actions that one can take to help with the smoking cessation. Like I brought up the idea, the suggestion about having a station where you would basically have like the smoking area and everyone in the house would know that that's where you go to smoke. And so she's wanting to propose that to her family members to see if that is helpful for them. So that'll be kind of another next step to try out too. I'm sorry for all the noise, background noise. But that's kind of where we are right now.
Great, thanks, Celine. It's nice to hear the follow-up. So I'm remembering, like, this is my memory, so help me, Celine, but this lady is like in her 50s-ish, 40s?
Yes, let me look up her exactly.
40 or 50, and she's like multiple chronic conditions, including end-stage renal disease, obviously, on dialysis, and has had some interest in reducing her smoking. So this was the follow-up, which is great. From the group, any clarifying questions for Celine? Anything you'd like to know more about before we sort of dive into some discussion on like what more or what next steps Celine could take, or recommendations? Clarifying questions? Will you remind me, Celine, as this patient, I think you said at the beginning, but she's not using any nicotine replacement right now. Is that correct?
No, not right now.
Okay, okay. Any other clarifying questions? Okay. Anybody of our faculty have any thoughts or ideas for Celine to help this patient and her partner continue to cut down and quit fully?
Yeah, this is Robin. Just had a question. And you said she's not using medicines. And I think I heard that she'd had a previous quit attempt without medicines. Has she ever used a medicine to help her with quitting?
Yes, she was on bupropion in the past. And
She was, okay.
at that time, there was also like some questions about some, I think, like gastro-related issues, and she didn't know if that was caused by that medication or something else. So she had stopped the bupropion, but I think that experience, I don't think it was necessarily due to the bupropion, but she found out there was some stomach issue that she had to get a surgery on. But I think having associated it with the time that she started that medication, she's not very open to medicines right away and would like to try without. Now, as far as the gum and the patches, I don't know if she's interested or would be open to that, but it seems like so far the strategies she's having for herself are helping, and it helps that her husband has cut down.
Okay, because one of the things, and I was hearing this, and again, not having all the picture, someone with end-stage renal disease usually has, and I think I heard the comment, multiple, other medical problems. There's lots of things going on. Just a comment of the end-stage renal disease. Chantix is not really an option in someone like this. That's a medicine that's eliminated by the kidney. So we would be looking for someone like and even bupropion, some of the, it's metabolized by the liver, but some of the metabolites, it's used with caution in people like this. So my kind of go-to, where I'd be thinking would be nicotine replacement therapy. Obviously, this is someone who already uses that. But the story that you're painting is really common, and of course, I'd love to have others chime in about this, that people really underestimate the addiction of nicotine and how powerful that is, and they think it's something I can just will myself away. If I'm stronger, I'll be able to do this. And we're quite honest with individuals to say that nicotine is every bit as addicting. Neil Benowitz, who is the world's expert on nicotine from UCSF, will always say, it's up there with heroin and crack cocaine in terms of its addictive. This is not something that's a bad habit. And so we really try to de-emphasize that there is an underlying thing that they can't control. Typically, people started this when they were teens, made some choices, and then got addicted, and it was beyond their control. So we like to emphasize that this is an addiction that we can treat, and the medicines are not a crutch. And sometimes people see that this is a crutch, and if I was stronger, I wouldn't need medicines. Well, we would never say someone with end-stage renal disease or diabetes, eat better. You can do this without medicines. We know that those are effective. So I think that would be, to kind of emphasize again that this is a difficult challenge, and it's a chronic condition. And just like with her kidney disease, and she's doing the dialysis and doing these things, that we can use, a two-pronged approach using the help that she's getting with the habits and the behaviors, but also dealing with the addiction part. And the nicotine replacement therapy would be a short term, recognizing that sounds like she has some concerns about using medicines, but for the short term to get her through this while she's stable and being a non-smoker. And I'm really encouraged to see that she's, with her husband going from 3 packs a day. And I don't know how much nicotine replacement therapy was using, but that would be someone that we would recommend probably higher doses, because 3 packs of cigarettes, that individual, most people get about anywhere from 1 to 3 milligrams per cigarette smoked. So if you're smoking 3 packs a day, you could be getting upwards of 90 milligrams of nicotine a day. So it's not uncommon for individuals that smoke that heavily to require higher replacement doses. So that would be something to kind of mention as he's transitioning down. If he needs more, not to worry about that, to help him get down to, because our goal for him would also be to be 0. But it's good. I mean, it sounds like you're doing, great work with this group, with these 2 clients. And I don't know, Karen, if you want to comment on the drug interaction with caffeine. I thought you might want to do that. Oops, maybe Karen's muted.
Yeah. Karen, if you're talking, we can't hear you, but feel free to talk over me and I'll hear you. Okay, go ahead. Yeah, go ahead. I think that's an important point, yeah.
So a couple things I wanted to point out is when I talk with patients, I emphasize that the medications will help you be more comfortable while you're quitting. And I think that that resonates with a lot of patients because it is a challenge. And if they've tried to quit before, which this woman has, she knows that it was difficult and that she was uncomfortable. And that there's no harm in trying to be more comfortable. You can draw a parallel. We like to use parallels and analogies when talking with patients. And one is that if you're having dental work, you wouldn't do it without Novocaine, right? You would want to have some Novocaine to make it more comfortable while they're drilling. This is really very similar. It's an approach that we use to make it more palatable, to make you more successful. And second, yes, the drug interaction with caffeine is always important because as patients quit, many of them will increase their caffeine intake because they think that they need more stimulation because they're losing the stimulation from the cigarettes when in fact there is a drug interaction. And when you quit smoking, then your caffeine levels will increase approximately on average 56%. And so we encourage patients to cut their caffeine intake by about 50% and not drink anything after, say, 1 o'clock in the afternoon, just to make sure that that caffeine is out of their system because we don't want them to have nicotine withdrawal, caffeine excess, and insomnia, which is what they'll have, because those three things in combination is a recipe for relapse.
Okay. Thank
That's
you.
great. Yeah, it's an important point, Karen. Thank you. That's great. Helpful. So real quick, I know everyone's watching the time. I am too. We're going to save our collaborative action plan update and do that over email because I think this conversation and all of our discussion on the didactic was so great today. So let's just we'll continue this discussion for a few more minutes and then we'll wrap up. But so South Carolina, Becky will follow up and we'll do some email exchange and people can hear the updates that way. Real quick, Bob Burns had a nice comment here about the housing situation, and I think it sounds like your patient may have left public housing voluntarily. Has there been any approach to reapproach the housing authority to explain why she gave up her unit and see if they can get her a higher spot on the waiting list as part of the housing issue?
I think we could definitely talk to our housing authority team about that. It was voluntary, but she didn't actually talk to the office as far as I know and let them know she was leaving, and it was right in the middle of them potentially finding out that her partner was living with her but wasn't on the lease, because when his health declined and the hospital kind of dropped him off with her, being that they were still legally married but separated at the time, she moved him into her place but hadn't added him to the lease. So I don't know what the situation was on the housing authorities end as far as what information they received or not about her departure, but it's definitely something we can look into still.
Yeah, that's great. Thanks, Bob. It's important, that like you're doing, Celine, the housing part and giving her stable housing would be great. So that's great. And I would say just for our guests too. So Celine, this is a patient I'm sort of filling in for you, Celine, but she presented this case just a couple months ago in the end of January, beginning of February.
Yeah.
Beginning of February. So it's been we're beginning of April-ish. So it's been about 2 months. So this progress, I think it just really speaks to the effectiveness and real benefit of having you, Celine, in this family's life. And this represents a lot of hard work and a lot of relationship building and a lot of continuity and establishing that trusted relationship. So I don't know, congrats, I guess I would say, and it's really beautiful to see that much progress. So, but other thoughts, I think those were super helpful thoughts on the pharmacotherapy side of things. Those are good takeaways for all of us. Are there any other questions or input from our faculty or any of the other participants? Okay, that's great. We're going to type all this up for you, Celine, and so you can have that, and we'll send it out to everybody because a lot of these are, good best practices and things that we can apply to other patients similar to this. So we will wrap up because we are almost at time. Yeah, right on time. So thanks again for joining us. Our next ECHO session is in 2 weeks, April 30th. I am actually not going to be here then, but Becky's going to take on this, incredible role of facilitator. I'll miss you all. I'm actually going to be away in Peru doing some volunteer work. So I'll be thinking about you all on Tuesday at noon while I'm high in the Andes Mountains. But I won't have any internet access, so I can't Zoom from there. Maybe I'll show some pictures next when I get back. But anyway, you'll have a great session. I will miss it. This has become a regular part of my life too. So no collaborative action plan update next week. What we're going to do instead is sort of just review how to use Zoom in case people are having trouble, and make sure like the sort of like that we're optimizing your Zoom experience, because there's ways to split your screen and make sure you see everyone's pictures and all of that. I want to make sure everybody knows how to do that. We are looking for volunteers for case presentations. So any patient cases or system level challenges or resident cases, if you're a housing authority kind of person, any volunteers or complexities. Remember, these cases are really to help you. So these are the challenges you're facing every day. And you bring the case and you'll get some helpful feedback and hopefully some answers to help you with your whatever problem you're having. The didactic topic at our next session is sure to be really important and interesting, which is about e-cigarettes and vaping. This is a big deal, both as we think about e-cigarettes and their potential role in the harm reduction space and cessation, and then the youth issues with e-cigarettes. We probably won't get through all that in 10 minutes, but it'll be a nice starting point and overview of the current landscape of e-cigarettes and vaping. Remember, the survey link is in the chat box, and take some time to do that survey. That really helps us. We appreciate your time. And don't forget to request your continuing education credits if you need them or want them. And with that, we'll say goodbye. Thanks again, Robin and Karen. We really appreciated your input and participating with us today. And we'll see you all soon.